So I think we are live. Good morning, everybody. Everybody is joining. And I'm meeting everybody from the Zoom platform. Right now, we have a few people waiting. So this is going to be the third lecture of Dr. Phillip McKee on the Back to Basics series of lectures that he is giving to the audience in DermPath, McKee DermPath, and in this time I'm inviting a few other groups that I found on the Facebook pages from surgical pathology. As everybody know, Dr. Phillip McKee is such a prominent dermatopathologist that has written many books, co-authored many books, published many papers, and he has kindly accepted to give us a couple of lectures that are going to be very valuable for many residents that are learning dermatopathology, and I thought that's going to be a great idea for us to have him share all his knowledge. I see people that I know already. Dr. Afshar from Owen Sound, one of my colleagues, and I'm hoping that many people from the University of Western Ontario will be joining us. I invited some of them and the residents, and I send invitations to all the continents, so I'm very confident that we're going to have a good audience. My name is Evan Pacheco, pathologist in Owen Sound and adjunct professor at the University of Western Ontario, and I welcome Dr. McKee and I thank him again for the following presentation on dysplastic nevus. Dr. McKee.
Okay, well, thank you very much for your kind introduction. This is a subject that I don't think anything in dermatopathology has caused more controversy and more problems for people than the dysplastic nevus. It certainly vies with Spitz nevus for complexity and controversy. And I put this slide up, this composite up first to show you a patient with dysplastic nevus syndrome. And on the left, we have a very typical dysplastic nevus, which we'll look at later. And then on the bottom two, the bread and butter, that's just to make the point that when I moved to Boston, dysplastic nevus literally became my bread and butter. I was looking at dysplastic nevi all day, every day, very often as many as 7 days a week. The workload was so heavy. And these slide trays on the right, they're to remind you all of the innumerable levels we used to have to look at because of the re-excisions that were inevitable with the majority of our dysplastic nevi. And I'll come back to that later. So it's a difficult topic to talk about, to try and make it interesting, because I was thinking about it and initially I thought, oh gosh, that's the last thing I want to talk about. It's just it's so divisive and people are so entrenched in their viewpoints. So I thought to myself, well, what can I do to make the lecture interesting? So I thought up some questions, and so this is what I'm going to talk about. Firstly, is dysplastic nevus a real entity? Can the clinicians recognize it, and can the pathologists recognize it? And if so, what are the criteria that we use to identify this nevus? And then the second question, which is the important one, I suppose, is does dysplastic nevus represent a melanoma precursor? And this, of course, is why we've ended up in the mess that we've got ourselves into with respect to re-excising incompletely excised lesions, because people have got it into their heads that dysplastic nevus may be a precursor to melanoma in any one given example, and if a bit gets left behind, that might regrow and then it'll turn into a melanoma, and that'll be a catastrophe for the patient and the pathologist and the clinician. And we'll get back to that later. And then I thought we need to get ourselves up to date. At least I had to get myself a bit up to date on the molecular changes that enable us to tell a dysplastic nevus from a common nevus from a melanoma. And there's been a lot of information that I came across on that one, which is really jolly interesting. And then the last question I want to touch on is, are re-excisions really necessary? And there is some interesting information in the recent literature on that. Now, the first description of the dysplastic nevus goes back to 1978, the original paper by Wallace Clark and his team. And I remember this very, very well because in 1978, I was still in London. I was working at St. John's Hospital for diseases of the skin. And I think it was in September of that year that I went to the monthly meeting of the dermatology section of the Royal Society of Medicine, which was a really nice meeting. The Royal Society of Medicine's building is in Wimpole Street, which is adjacent to Harley Street. So it's in the very center of the private sector of dermatology. Anyway, Wallace Clark wrote this paper up, and in that meeting, I saw my first patient with the BK mole syndrome. And it was fantastic because prior to that paper, I'd been taught to use the term activated nevus, and we didn't really know what an activated nevus was, but when we saw a nevus that looked funny, we used to write this in our reports, and the clinicians didn't know what that meant, and we didn't really know either. So suddenly we had this epiphany. We suddenly realized we were looking at dysplastic nevi. And in the same year, Lynch and his co-authors described the familial atypical mole melanoma syndrome. So those were the two landmark papers. Now, one of the things that has beset the pathology world has been this concept that we don't have reliability between one group and another in terms of grading dysplastic nevi, that people are always saying there's lack of concordance. And one of the other things people say is that there aren't any recognized features which you can use to grade a dysplastic nevus. And this, of course, is because they haven't gone back to the literature. In 1997, Weinstock, Barnhill, Rhodes, etc., wrote this very useful paper in the Archives of Dermatology, in which they gave the criteria by which you grade a dysplastic nevus in terms of cytological atypia, whether it's mild, moderate, or severe. And it's very clear, and I'll show you that table later on. And so I never really understood why people had a problem with grading atypia, because the rules are very simple. You've just got to look at the slide carefully and then work it out, and you come out with mild, moderate, or severe. And I think most people, when they say there's no concordance, it's because they were using some other grading system, or perhaps they invented their own when they were looking at slides. But in any event, they are easy to grade if you follow the rules. Now, the next important paper came out, and again, this was from David Elder and Wallace Clark, which was a paper in Cancer, which showed that patients could get a dysplastic nevus in the absence of the BK mole syndrome. So they first described the sporadic dysplastic nevus, and that was a very important publication. And then that's when the trouble started. This is the paper that caused all the trouble by the late Bernie Ackerman, who wrote this paper in Histopathology in which he essentially debunked the concept of dysplastic nevus, dysplasia, dysplastic cells, and said that they really didn't exist and they should all be called common nevi. And this then resulted, I think, now, this is just my personal opinion, and others will have a different view, but I really do think that we ended up with two schools of thought. There were those who followed the Wallace-Clark school of thought, and then there were those who followed the Bernie Ackerman school of thought. And so if you were Wallace-Clark, you believed in dysplastic nevi, and if you were Bernie Ackerman, you didn't. And I think that influenced the attitude to dysplastic nevi for a very long time. And I'm not sure that it's really even been resolved to this day, although from my perspective, I've never had a problem recognizing a dysplastic nevus. To my mind, it's different from a banal nevus, and I'll show you why in a moment or two. So I borrowed this paper from maskin.com, or this photograph, and it shows you 4 dysplastic nevi along the top and 4 melanomas along the bottom, and you can see how clinically there's a considerable overlap between dysplastic nevus and melanoma. And in any one given case, it might be quite difficult to be sure which you're looking at. Now, if we use the criteria that I'm going to come to in a moment or two, it's generally thought that 1% of the general population will have at least one dysplastic nevus, and that if you have a patient with melanoma, 43% of melanoma patients have one or more dysplastic nevi. And so we have to think about banal nevi and dysplastic nevi and how they differ. Now, I had great problems getting a decent picture of a junctional banal nevus, and these are 2 such examples. And I've never been very comfortable with this size concept of 5 millimeters or less, but that's what's in the literature and that's what people believe. So I think we're stuck with it. So basically, a banal nevus is generally smaller or no more than 5 millimeters in diameter. And as you see from these 2 pictures, it's uniformly pigmented, it's circumscribed, and it has regular borders. Now, such banal melanocytic nevi, they can be junctional, they can be compound or dermal, and we'll have a look at that later on. Now, I don't know whether this is true or not, but a lot of the books reckon that the average person has 20 to 40 nevi. Well, I don't have any nevi, so there's something wrong with me, or these figures aren't right, but that's what the literature would tell you. And they develop in adolescence, and as you get a bit older, they mature, they become compound, and then they become dermal. And by the 3rd decade, you've got as many nevi as you're going to have. And as you get older, they regress and they present in the older age group as a sort of a dome-shaped pale or pink nodule. Now, if we contrast that with the dysplastic nevus, these by definition are said to be greater than 5 millimeters in diameter. Now, I've never quite worked out why they have to be greater than 5 millimeters in diameter, because I don't know what tells a dysplastic nevus melanocyte how it has to be 5 millimeters before it can be dysplastic histologically, but that's what they say. So that's the information that you'll get in the literature. And on the right, you can see that it's asymmetrical, it's irregular, the border, and there's variable pigmentation, but it's not a very worrisome lesion. And I don't think any clinician would look at that and say, oh gosh, that's melanoma, but they would recognize it as a dysplastic nevus, or if you like, clinically an atypical nevus. And they can present most parts of the body. They tend not to be seen on the face, so be careful diagnosing a dysplastic nevus on the face. And here are some pictures of dysplastic nevi. There's dermoscopy there, and this is a nice big one, where you can see the irregular border. It's asymmetrical, it's very variably pigmented, and I imagine the clinician might have been worried about melanoma, and there's another one there with very variable pigmentation and an irregular border. But those were all, as I understand it, were regular dysplastic nevi, not melanoma on histology. And this is a patient, I borrowed this from the Hellenic Dermatological Atlas, a young girl with dysplastic nevus syndrome, with lots and lots of nevi all over the place. And this is the one I showed you earlier. Again, a patient with dysplastic nevus syndrome. And then Dr. Cheng Yu Wang from Taiwan very kindly shared some pictures with me. And this is another patient with dysplastic nevus syndrome. And there's a very worrisome lesion there. It's well, you can't tell, but it is quite large. It's variably pigmented. It is asymmetrical. There's another one. All sorts of nevi on that patient. And he also supplied me with this one, a very irregular lesion, and this one, again, showing a very irregular border. So here's the, to me, the point of reference that we use when we're thinking about dysplastic nevus is the lentiginous junction or the lentiginous compound nevus. And so when we're thinking of a dysplastic nevus, we relate it to what a banal nevus looks like, and we see what differences there are. And the most obvious in this upper and in the lower, obviously, are that the nests tend to be located at the tips of the rete ridges, as you see in the center there. And there are 3 lovely junctional nests located right at the tip of the rete ridge. The nevus cells, they're type A nevus cells. They have not too much cytoplasm, and they have either hyperchromatic or they have vesicular nuclei with small nucleoli. And when we get to the grading part of the talk, you'll notice that the nucleus of a banal melanocytic nevus is the same size or smaller than the nucleus of the basal layer of the keratinocytes. And that's important when we come to grading. And here's a compound lentiginous banal nevus, again showing the nevus cells at the tips of the rete ridges. And this, in fact, may be a congenital nevus because it's going quite deeply down into the dermis. And on the right-hand side, you can see a nice junctional nest with type A nevus cells in the dermis with vesicular nuclei, and they have rather small nucleoli. So let's contrast those images with a dysplastic nevus, and what are the differences? Well, the first thing that you notice And I think it's why it's a low power diagnosis. As soon as you look down the microscope, you see a nevus, but it's completely disorganized. It's an absolute muddle. It doesn't show the rete-tip prominence that you see in a banal nevus. The junctional nests are all over the place. And this low power view shows you the second feature you often see in a dysplastic nevus. This is the compound bit on the right, and this is the junctional bit on the left, and this comprises the shoulder that we talk about in dysplastic nevi. And architectural disorder comprises a variety of features. One is that that it's lentiginous and nested. Two is the nests are abnormally located. They may be at the tip of the rete ridge, but they're also at the sides of the rete ridge. They may be on the tips of the dermal papillae. They're often horizontally orientated, which I'll show you later, and frequently they show bridging. Now, it's important that you don't mistake bridging of keratinocytes of one rete ridge to another. It's got to be nevus nests that are bridging, and sometimes that can be a little bit difficult. Very often dysplastic nevi show very fine pigmentation, and sometimes this can give it a rather slightly greenish appearance on H&E. And then when we look at the nevus, we have to think about the atypia. And it's very important that you find cytological atypia. If what you think is a dysplastic nevus has no cytological atypia whatsoever, then with respect to the new WHO classification, we would call that a Clark's nevus. So we would distinguish Clark's nevus from dysplastic nevus by virtue of a Clark's nevus showing no cytological atypia. Now, until recently, we graded cytological atypia into mild, moderate, and severe, and I'll get back to that later. But with the new classification and the new WHO book, they've replaced that with low grade or high grade, which in a way makes a lot more sense. And we'll talk of that in detail later. Mitoses they're very rare in a dysplastic nevus. I think if you start finding mitoses in the junctional component of a dysplastic nevus, you've got to start wondering, are you missing a dysplastic? Are you miscalling an in situ melanoma or dysplastic nevus? So be careful with mitoses. And for my definition, one doesn't have pagetoid spread. Now, the WHO, I think, says you can have one or two cells just sort of up to the mid-prickle cell there, one or two, but I get very uncomfortable about that, and it would prompt me to do more levels because I think I'd probably find in situ melanoma in the deeper sections. But there is a little bit of discussion on that. And then we have the host response. We have the fibroplasia. And I think that's why people have had this confusion in a way between banal nevus or a common nevus and a dysplastic nevus, is that sometimes a banal nevus can show a host response. And so that problem has been got over in the new WHO by calling them Clark's nevi. And so I think that's if you like, that bridges the gap between the banal nevus, the dysplastic nevus, the in-between lesion that's devoid of cytological atypia. We can call that a Clark's nevus, and then I think maybe everybody's happier. Whoops. I've just lost my Then the other features that you see at low power examination, you can see the increased vascularity, as you see on the bottom image. You see lymphocytes in the dermis, and you see some melanin pigmentation. And so it's the sum total of all of these features that you really do take in at low power that enable you to instinctively say, this is a dysplastic nevus, or it isn't. And I think it's a matter of familiarity. It depends upon what environment you live in, what climate, what latitude you live in, as to whether you see more or less dysplastic nevi, because dysplastic nevi are partly induced by UVB, and so you tend to see them a lot more in hotter climates. Certainly, when I moved to America, gosh, as I said to you at the very start, I was seeing a dozen, 20, 30 dysplastic nevi every day, whereas in the UK, I might see one or two. So, you know, the more of them you see, the more used to you get, and the more easy it is to recognize them. So here's a nice, that's the same lesion showing you it in slightly more detail. You can see this is the compound part, and there's the dermal component underneath. Those are type B nevus cells. They look like lymphocytes. They're totally benign. You don't need to worry about them. And there's the junctional component, which you can see is lentiginous, and it's nested. And you can see the increased vascularity in the dermis. You can see the lymphocytic infiltration. You can get a hint of the fibroplasia around the rete ridges. So one of the features I'd like to emphasize is the abnormal location of the nests. And if we look at these two images, this is a higher power image of that. You can see that the nests are, this one is on the side of a rete ridge. This one looks as if it's coming from the inter-rete ridge epidermis. And here at the bottom, you can see, well, it's almost bridging. I'm not quite sure what's going on there, because that's a bit of a rete ridge there. But if you look at on the left-hand side, you get the impression that they may well be bridging. And there's obviously nice fibroplasia, lots of melanin pigment in the dermis, numerous eosinophils or lymphocytes. There's another one. Here's a close-up view, and there you see a junctional nest there. There's one arising at the side. This one again is arising at the side. Lots and lots of melanin pigment, lymphocytes, and increased vascularity. And then a common feature you see in dysplastic nevus, particularly with severely atypical ones, is bridging and horizontal orientation. And this is a perfect example where you can see, I'm just trying to work it out. That's 1, 2, 3, oh, I don't know. It's bridging across 5 or 6 rete ridges, and they're all horizontally orientated. But underneath, you can see the dermal component composed of type B nevus cells, and there's no evidence of any pagetoid spread. Now, I touched on the lack of concordance, and I gave you my reasoning why. And this is the paper I mentioned by Weinstock and David Elder and so on from 1997. And these were the criteria that we used to use. And we used, it was a keratinocyte in the mid-prickle cell layer, and mild was approximately the same size. moderate was 1 to 2 times bigger, and severe was two or more. And there would be no nuclei mildly atypical. They might be absent or small and moderate. They would be prominent and enlarged in severe. And the cytoplasm would be minimal, but sometimes abundant with dusty pigmentation and mild. And with severe, it would become very abundant. And I'll show you some photographs of those in a moment or two. Now, I did mention to you that the WHO have changed the grading system, and they've replaced mild, moderate, and severe. They've actually got rid of mild and included that with just with the Banal nevus. I'm not quite sure why they've done that, because the architecture remains the same. And I have a feeling that most people, when they see a mildly, what they would have called the mildly dysplastic nevus in the old days, they'll shove it into the low-grade category. But anyway, I don't suppose that matters terribly. It's very important that you don't misdiagnose dysplastic nevi when there's something else. And so it's important that you always have clinical information. So if you're looking at a nevus of the external genitalia, particularly in females, you don't mistake a genital type nevus for a dysplastic nevus. It's important that you know whether there's a past history of a biopsy at that site, so that you don't mistake a recurrent nevus from for a dysplastic nevus. And I put this at the bottom because I still think we have the Ackerman school of thought versus the non-Ackerman or the Wallace-Clark school. So this is the 2018 classification. So what used to be called mild dysplasia, in which the nucleus was the same size or less than the nucleus of a basal keratinocyte, they've decided to not regard that as a dysplastic nevus. So that's fact of life, whether one likes it or not. That's just the way it is. And moderate dysplasia, which is 1 to 1.5 times the size of the nucleus of a basal keratinocyte, is low, and greater than 1.5 is high-grade dysplasia. And there are the other features there. When I was working in the UK, the UK was very, very behind the US, at least 10 years behind. And I suppose that's the same for most things. The US leads and then the UK follows shortly or sooner or later. And so when I was practicing, nobody graded dysplastic nevi at all. And we never re-excised them because they were all fully excised in the first place. And so when I moved to Boston, I didn't know what had hit me, because suddenly I had to start grading dysplastic nevi, which I'd never done. But as I mentioned earlier, if you follow the rules and regulations for grading them, it's not that difficult. And then we had the problem of partial biopsies. And so we were always ending up recommending a re-excision, and we'll get back to that in shortly to talk about whether it's worthwhile or not. So if you haven't got the 2018 WHO book, if you can afford it, I would strongly recommend that you get a copy, and then you can see this table. But if you want to review this table, if you look at the lecture again, you can pause it and then have a look at that grading. I don't want to spend any more time on it. So in the old days, this was a typical mild cytological atypia, nuclei hyperchromatic, the same size as the nucleus of the mid-prickle cell layer. And this, you can see this very finely granular or cytoplasm, which is very characteristic of a dysplastic nevus. But as I've said, we just in theory, we discount those. And here we have a case that Ivan very kindly shared with me. It's a lovely dysplastic nevus. You can see there's architectural disorder. You can see lovely bridging, crossing 1, 2, 3, crossing 3 nests. The cells are horizontally orientated. There are lymphocytes, increased vascularity, pigment incontinence. And the nuclei are a little bit larger than the basal keratinocyte, but they're not that big. So this would fit with low grade dysplasia. And here's another one. Again, if we're using the basal keratinocyte as our yardstick, then the nuclei are a bit larger, but they're not that much larger. They tend to be rather hyperchromatic. So again, this would be low-grade cytological atypia. And if we look at this one, here you can see the cells are much larger, lots of cytoplasm, very large nucleoli, prominent nucleoli, and on the right you can see very large hyperchromatic nuclei. So that's severe cytological atypia. And then we have fibroplasia. This is lamellar fibroplasia, where you can see the lamellae forming distinct zones of fibrous tissue. And when they get homogeneous, we call this eosinophilic fibroplasia. And again, this field showing you the amount of pigmentation that you commonly get. And here we see increased vascularity and lymphocytic infiltration. You can tell at this magnification, this is severely dysplastic because the nuclei are very large. Now I'm going to show you a series of cases, and this is the one that I just showed you a moment or two that Ivan shared with me. So this is a lentiginous I think it's compound nevus. I think there's a bit of dermal component there, but it's hard to tell. But we'll look at it in higher magnification. And there's that lovely bridging that we were looking at earlier. And here's a close-up view. And you can see that by and large, the nuclei are larger than the basal keratinocytes, if you can find that. There they are there, but they're not greater than 1.5 times. So the overall impression with that field would be low-grade atypia. Now, I don't think that I would necessarily, if I found one cell that was double the size of a keratinocyte nucleus and the rest was all mild cytological atypia, I don't think one cell is going to swing me into severe atypia. But by and large, most cases I think can be easily sorted into one or the other. And here's a nice example. Here you can see there's the shoulder there. You can see the dermal component there. There's the dermal component on the right side. There are those horizontally orientated nests. In the bottom right, you see the dermal component. And then the next slide, this shows you a high power of the junctional component. Look at the size of that nucleus there and there and there. Those are severely atypical nuclei. So this is high grade atypia, but you'll notice there's variation. Some cells are smaller. You see that cell on its own is almost the same size. If there's a basal keratinocyte nucleus there, that cell is the same size, whereas this cell is bigger. These are bigger. And these are huge. So there is sufficiently huge nuclei there to regard that as severe cytological atypia. Now, what's happened? Oh, I seem to have lost my... Oh, whoops, I go back. This is a case that Antonina shared with me, and it's a really lovely example. It's compound. There's the shoulder on either side. There's the compound bit there. I just remembered last time we were having some problems with the sound and the image not being synchronized. Are we still having that, or is everything okay?
I hear everything to be fine here. I haven't
Good.
heard any comments on Facebook, and I
Okay.
don't have any questions on Facebook yet.
Oh, good, good. Well, that's very reassuring, because it did disturb me that, because when I looked at myself, there was very appreciable. It was very obvious delay. But anyway, when we look at this, you see, when you look at it at low power, the junctional component looks a complete mess. It's sort of instantly obvious that it's very disorganized. And when we look at it at closer magnification, you can see nests coming off the side, coming off the side, coming off the tips as well. Some of them do come off the tips. And you can see there's nice bridging there. Lots of fibroplasia, lots of pigment. Then the next, there's another view there showing cytological atypia. I don't think those are much, they're a little bit, they're roughly the same size as the nucleus of a basal keratinocyte. So I think this is showing mild cytological atypia, but it's very, very jumbled up. Beautiful fibroplasia there. I see. Let me just... There we are. And here are some more views. I just wanted to look at that one in particular. If you compare those nuclei with basal keratinocytes, they're a little bit larger, but not much. So I think we would regard this as a lentiginous compound, dysplastic nevus with mild cytological atypia. And here's another case that Antonina shared with me. This is a junctional lesion. You can see an abnormal location of nests. It's lentiginous and junctional. There's very nice fibroplasia. And on high power, the nuclei are not particularly large. So again, I would call this mild, what it would be low grade dysplastic nevus. It just shows you old habits die hard, and I tend to switch between old terminology and new terminology, but I've got to practice so that I keep myself up to date. And then this is a case that Luca Conti from Turin shared with us on Facebook on McKee derm. There's a very worrisome lesion. Now, I don't like to comment too much on dermoscopy, but there's something very worrying about that lesion. It's a lumbar region of a male aged 33, and the patient has dysplastic nevus syndrome. And you can see that something went very wrong when I was cleaning the background there, and I just noticed that about 10 minutes before the presentation. So you can see that that didn't work very well. But anyway, here we see a lentiginous lesion. There's a junctional nest there coming from the overlying arete ridge. And there's the dermal component there, looking quite banal, looking quite bland. And here we see just a lentiginous growth there, and that's the SOX10 of that field there. So it's just confirming there is no evidence of any upward spread in that lesion. And here we can see where it's getting much more juicy. This is the compound part. There's the compound part there, and there it is there. And you see the architecture of that lesion is totally haywire. And unfortunately, I don't have any higher magnifications, but this was severely atypical, and so would be a high-grade lesion. There's another field there. There's the SOX10 showing you how much proliferation's going on, and HMB45 showing you the dermal components is not stained, and that's perhaps a little bit higher power. I think you can probably appreciate severe cytological atypia in that picture. And then this is a series of wonderful cases that Vicky Kazlowskaya and John Han-Ho from Kiko shared with me. It's absolutely fantastic cases. There are two biopsies from one patient, and I think he had multiple dysplastic nevi. I don't know whether he had dysplastic nevus syndrome or not. But anyway, these are three cuts through one lesion, and you can see a compound component. There's the dermal component in the middle, and these look like little lymphocytes. So it doesn't look worrisome at that low power. And there we have composites showing the junctional component to the edge on the shoulder. There's more of the shoulder there. And look at that for bridging. You've got these great sausage-like nests that they're quite staggering with, as you'll see, the severe cytological atypia. There's the dermal component, which is quite bland, and it doesn't worry me in the slightest. There's no evidence of any pagetoid spread, none whatsoever. There are no mitoses. And this is, I think this is a different lesion from the same patient with a more extensive dermal component. Again, you've got these sausage-like bridged junctional nests. They're very striking. And there's some close-up views there. And there's the dermal component again. It's not worrisome. So that was a high-grade compound dysplastic nevus. Now, people come in, just talk a lot about, are dysplastic nevi precursors to melanoma? And there's a lot of controversy over this, and I don't think we truthfully have a true idea as to whether any one particular dysplastic nevus is of itself a precursor to melanoma. But if you look at it from the other way around, you see melanoma arising in dysplastic nevi from time to time, but equally well, you see melanoma arising from a banal nevus. So a melanoma may arise itself de novo, or it may arise in a background of dysplastic nevus, or it may arise in the background of a banal nevus. So the likelihood of any one dysplastic nevus becoming malignant is very, very remote. But if you are a patient with dysplastic nevus syndrome and you have hundreds of lesions, then I suppose the risk of any one lesion progressing to melanoma may well be much higher. But on top of that, patients with dysplastic nevus syndrome develop multiple melanomas that do not necessarily appear to be arising in a background of dysplastic nevus. So in the context of the syndrome, dysplastic nevus may progress to melanoma, but the patient may also get melanoma as a de novo phenomenon. And as I'll show you later, on a molecular level, there are sufficient differences that enable one to tell the difference between a banal nevus from a dysplastic nevus and from a melanoma. There is an apparent continuum, but I don't know whether the biological behavior necessarily follows that continuum, and we'll get back to that later. So this was a biopsy. It was from a female, and it was from the thigh, and there's a compound lesion. You can see some dermal component there, and then there's this very extensive shoulder. And we'll look at this at closer magnification. There's a lentiginous component in the shoulder. There's that compound bit where the dermal component is quite banal. These are type B lymphocytes, melanocytes, so they're not worrying. But there you can see nice architectural disorder with bridging. And but as we worked our way further towards the right-hand side of the lesion, there you see it's still dysplastic nevus, but a little bit further on, you've got obvious pagetoid spread, which becomes very marked over here. And so, and there's another field below. I think the next slide shows you that in high power. Yes, that this was at one extreme, where you can see there's clearly in situ melanoma. So that's one example of a dysplastic nevus that did evolve into melanoma. And here's another case which is equally interesting, although it's a bit. I'm not quite sure that I've ever made up my mind quite what was going on. It's a compound lesion. There's the shoulder there. This is, if we look at this bit, this is here and here, and there are funny nests. I'm not sure what I make of them, and you'll see why I'm uncertain when I show you the next group of pictures. But this shows you the dysplastic bit. There's lovely lamellar fibroplasia, there, lymphocyte vascularity. But then when we moved further across the lesion, this is what you see. You see a bit of residual melanocytes. There they are in high power there with lots of pigment. But there we have what I interpret as complete regression. There's just nothing left, but it looks to me as if there has been melanoma has arisen in that lesion, and it's completely regressed, and there's a scar. And so if I go back now, that's why, oh, it doesn't want to go back. Why is that? Let me just see if I can go back. Whoops. There, that's why I'm not sure what these nests are. I wasn't so worried about them until I saw that regression, and I don't know what to make of those, to be honest with you. I think if I was faced with this, they worry me, but I don't think I could make a diagnosis. I certainly wouldn't call that melanoma, but it would concern me.
Dr. McKee?
But then we have this, yes?
Could you please clarify for the residents, what do you mean by regression?
Okay. Well, what's happened? What's happened is there's an abrupt stop. Let me see if I can go back. I can. There's you see, that is the left-hand side of the lesion. And so we're going from the left to the right. And then when we get to, and so you can see there's a compound lesion with a dermal component there. And then when we go to the next slide, this is the other side. The images have been reversed. So that's, unfortunately, that's just because of the way I use them in Photoshop. But this is the continuation of the nevus that we saw in the previous slide. So there's this element of nevus here and here, and then if you look at the epidermis, there is no junction activity at all there. That I don't think I can even make out a melanocyte. And then the dermis has got this very homogeneous scar. Well, it's scar tissue, but it's not a surgical scar with neovascularization and scattered lymphocytes. So my interpretation of that, the patient had not had previous treatment or surgery, and so my interpretation of that was that there must have been regression of a melanoma. That's what we thought anyway. Okay.
Thank you.
Okay, Doc. Let me just see, I've lost my control again. Okay, now, so this is the bit, this is, to my mind, the most controversial bit about dysplastic nevi, re-excision or not to re-excise. And when I was in Boston, we were, if you like, united by Harvard Medical School, and these were our guidelines. If the dysplastic nevus involved the margin, if it was mildly atypical, we didn't re-excise it. If it was moderately atypical, which we now call low-grade dysplasia, we would have invariably recommended a re-excision with 2 millimeter lesion-free margins. And if it involved a margin with severe cytological atypia, we would recommend a re-excision with 5 millimeter margins. The reasoning for that was that people assumed that a severely atypical dysplastic nevus may have progressed to an in situ melanoma, and we weren't seeing that. So it was felt it would be safer to re-excise it, and that would solve the problem. And so for my time in Boston, those were the rules. You didn't have any option, and if I didn't recommend a re-excision, then the dermatologist would phone me up and they'd say, you haven't said whether I should re-excise this or not. Please, can you amend your report and recommend re-excision? So the dermatologist wanted the pathologist to take the blame, if you like, for having it re-excised. So the shoulder, it sat on our shoulders. And I was never very convinced that this was worthwhile at all. For the vast majority of cases, you spent hours looking at re-excisions and you didn't find anything, or you found a little bit of residual dysplastic nevus, and to find melanoma was very, very exceptional. And so I mean, I went along because I had to do what the system dictated, but I was never desperately convinced that it was terribly valuable. And I always thought to myself, if I could persuade the dermatologist to use a larger punch biopsy to get the whole thing out in the first place, we could have solved that problem. But for whatever reason, that never happened. So I had a look at the literature to see what people thought. Now, here's a wonderful paper by Nima Ardakani from Australia. He's one of our members, and he's a really top-notch molecular biologist, in addition to being a wonderful dermatopathologist. And this article I'd recommend to everybody. Dysplastic Clark nevi in the era of molecular pathology. It really is, it covers everything, and I found it tremendously useful. The only thing is, I wish I could remember all of the molecular detail, which I enjoyed reading, and then it goes out of my head. But I thought I wanted to show you this sentence, which says, well, if a severely dysplastic nevus involved margins, 62% of Australian dermatologists would aim for a re-excision, and 37% would choose a 5mm clearance, which is a bit similar to Boston. And then he makes the comment, these surveys highlight a trend towards more aggressive management of dysplastic nevus in recent years. However, there is still little evidence to justify this approach. And I was quite heartened to read that. So then I went delving to see what else I can find. And here's a paper from the JAD 2017. And here they did a retrospective study of 451 adult patients. And what they found was of the 451, a re-excision was performed on 36.5%, and 2 melanomas were diagnosed in those re-excisions. So their comment, their feeling on the matter, I suppose, was that you could take home the message that you didn't need to always re-excise severely dysplastic nevus involving a margin, but they left it a bit hazy, so I didn't find that paper too helpful. And then there's another paper which was a bit more useful. This one, they studied. It was a meta-analysis of 1,809 mildly and moderately dysplastic nevi, and what they showed was re-excision resulted in a clinically significant alteration of the diagnosis in only one case out of 1,809, which is 0.2%. So that would suggest that re-excising is a waste of time. And then there's this last paper where they assessed a total of published data of 5,293 patients with dysplastic nevi, and 6 patients subsequently developed melanoma in cases where they didn't re-excise the lesion, and 5 patients developed melanoma in patients who did have a re-excision. So 6 and 5 is pretty much the same. So one does get the sense that re-excisions are not necessarily are not always necessary. Now, where does that put me if I was reporting a dysplastic nevus? It still leaves me with the difficulties of my training, if you like, when I was in Boston, and my concern that if I'm looking at part of a lesion, I haven't seen the rest of it. So how do I make a diagnosis on a partial biopsy? And the answer is I can't. And so I'm still going to end up recommending a re-excision, not because I'm necessarily worried that the lesion I have seen itself is going to recur, but it's because I haven't seen all of the lesion. It's the same reasoning why one recommends a re-excision of a partially biopsied Spitz nevus. It's not necessarily because what you see worries you, it's because what you haven't seen worries you. So I think the jury's still out on re-excisions. I'm not convinced that we really know whether we need to do them or not. And to be honest with you, I'd be much happier if the dermatologists would get it in their heads to fully excise lesions that worry them. You see, I don't really understand it. If you are a clinician and you have a patient, let's say, with dysplastic nevus syndrome, and there's a 7 millimeter irregular, variably pigmented lesion, why do you do a punch biopsy of that? Surely you would be better off excising it. Now, it takes longer to excise it. Sure, I understand that. And there's more follow up because you've got to get the patient back to get the sutures out. But to my mind, it defeats the object of the exercise. The exercise being, is this a melanoma? If you only biopsy part of it, then you can't answer the question. So the only solution from my perspective as a pragmatic dermatopathologist where cosmetics does not enter into my mind, time doesn't enter into my mind, I'm not constrained by either of those. To my mind, excise them fully in the first place is the only way to solve the dilemma. And the clinicians I know are going to argue with me, and that's fine. But you see, they look at things from a different perspective from me. So I have to give them the opinion that I take from my perspective. And then lastly, no, well, I've gone over that. Lastly, I wanted to put this figure in. Now, I'm not going to answer questions on this because this is way out of my league, but I thought it was, this is a table or a figure that Nima produced of dysplastic nevus showing the various molecular abnormalities that one may encounter with dysplastic nevus. And what's interesting is that dysplastic nevi do show the ultraviolet signature with CT and double CT substitutions that you associate with exposure to ultraviolet light. So we know that ultraviolet light is of importance in the pathogenesis of a dysplastic nevus. We also know that we get copy number variations, in particular, hemizygous deletion of chromosome 9p21, which is the p16 gene. So we know we get heterozygous deletion of p16. And then there are these somatic mutations, non-V60B RAF and so on. And in the bottom right, I thought this is an interesting section of their paper where they talk about the influences of the environment of the nevus cells themselves, the surrounding keratinocytes, the hair follicular epithelium, the vascularity, and so on, and the complexity of the molecular phenotype of a dysplastic nevus. And it's very, very interesting, beautifully discussed. And their conclusion was that dysplastic nevus sits sort of halfway between a banal nevus and an in situ melanoma. And then, so my conclusions is I've never understood this problem with recognizing a dysplastic nevus anyway. I think that there was, I do know way back in the day that there was a lot of rivalry between Wallace Clark and Bernie Ackerman. Wallace Clark taught Bernie, and Bernie, so Wallace Clark was Bernie's mentor, but then I think they had some sort of a disagreement, shall we say. And I never really knew what was going on, but really Wallace Clark began the story of dysplastic nevus, and then Bernie Ackerman began the story of not believing in dysplastic nevus. But I always felt that it's a recognizable entity. Clinically, my dermatology friends all recognize them. They're not stupid. So if they think a thing is dysplastic because of the criteria they use, well, then that's what it is. And similarly, I'm not stupid and you're not stupid. If you follow the criteria, it's easy to recognize histologically. So I think that should be put to bed. I think one shouldn't be having this discussion anymore. Now, whether any one particular dysplastic nevus is a precursor for melanoma is still controversial. It's still uncertain, but it would seem likely that high-grade lesions might represent a precursor or might evolve into a melanoma, but you couldn't say which one would, but there is a possibility that some might. And I mentioned the molecular studies, and I've mentioned the issue of re-excision and how I still remain uncomfortable with it. And that's all I have to say now. So I have to show you the last picture, don't I?
Mm-hmm.
This is now there you are. For those of you who don't like dysplastic nevus, and those of you who know me very well, you know that my passion in life is driving like a maniac. And that's such a gorgeous picture, isn't it? So that's the end of my talk. Now shall I close my PowerPoint?
I think that you can still leave it up. And I have a few questions from Facebook and from Zoom. I can start with the Zoom questions. I think it's the first question I saw here. They're congratulating you because of your presentation was excellent. Then here, the question from Dr. Julio Salamanca. I think he's from Nicaragua. How should be called a nevus that meets most of the clinical and histologic criteria of dysplastic nevus, but does not reach the 5 millimeter in diameter characteristics? And
yeah.
I think that question also can be tying with another question that another person asked in Facebook. What will be the role of age in your diagnosis? Will the age of a patient, you will take into consideration the age of the patient for grading melanocytic atypical lesions? As some young individuals can show juicy cytologic atypia. Dr. Raj Guru, I'm not sure where she is from here.
Well, let me answer the first question first. I touched on that. To me, a dysplastic nevus is defined by its histology. I've never measured them, so I can't answer the question of size, but I've never quite seen why a dysplastic nevus couldn't be 3 millimeters or 4 millimeters, just the same as it could be 6 or 7. If it looks like a dysplastic nevus, then it is a dysplastic nevus. And that's all there is to it. It's a bit like saying a dog isn't a dog until it's 1 year old. You know, it makes no sense to me. To me, it's as stupid as that. So I don't really hold with the notion that it has to be of a particular size to be a dysplastic nevus. I think that's nonsense. Now, the second question, well, you see, lots of nevi show cytological atypia. Lots of them do, but they aren't dysplastic. For example, genital type nevi, nevus of special sites, they all show cytological atypia. But it's part of the nevus. You don't grade it because it's not thought to be of any significance. It's just a feature. Deep penetrating nevi show cytological atypia. Neonatal nevi show cytological atypia. Nevi in pregnancy can show cytological atypia. All sorts of nevi, nevi of the scalp, nevi of the ear can have cytological atypia. It has to be, you have to take it in context. First of all, you need to know the clinical information. You need to know where the lesion comes from, so that it's not so that you close your mind. But if someone tells you this is a 6 millimeter diameter irregular pigmented lesion from the vulva of an 18-year-old girl, then you know before you start that it's a genital type nevus. Now, is it conceivable that you could get a dysplastic nevus of the vulva in an 18-year-old girl? I'm sure you could, but then it would look like a dysplastic nevus. It wouldn't look like a genital type nevus. They look different. So you wouldn't have that problem. So you've got to, if you follow, you see, it's all a matter of following the rules. The rules are simple. That slide I showed you where I talked about the histology of a dysplastic nevus with architectural disorder, cytological atypia, fibroplasia, abnormally located nests, bridging, all of that stuff. Those features are always a dysplastic nevus, unless it's a dysplastic nevus with associated melanoma, then it's both. But if it doesn't have melanoma, then it's a dysplastic nevus. Now, does the age of the patient matter? That's a good question. I think one tends not to see them as the patient grows older in terms of great, well, certainly put it another way around, I'd be uncomfortable diagnosing a dysplastic nevus in a 50 or 60-year-old. I'd be very keen to do a lot more levels and make sure there wasn't a melanoma. It's not to say it mightn't happen, but you don't see it very often. It's
Now, I have another question that's going to tie to the last subject that you are embracing right now. It's from Dr. Mariama Joseph on Facebook from University of Western Ontario. Thank you so much, Dr. McKee. Can you give the criteria to distinguish dysplastic nevus from special site nevus, genital / acral, etc.? So,
okay. Well, a genital type nevus is it's very, very distinctive. You recognize it at scan palm. If it's compound, it's often a bit dome-shaped. It's sometimes polypoid. The dermal bit sometimes protrudes down as a sort of a polypoid component. And when you look at the junctional component, they're composed of very, very large nests. They're very discohesive. They have a retraction artifact, and they're intensely pigmented. The dermal component may be pleomorphic. You may see pleomorphism in the superficial dermal component. You may see a little bit of impaired maturation. You may see mitotic figures in both the junctional and dermal components. So they look very different. I wish I thought of that. I could have put up a, let me just see if I can just, let me do something. If I can move these, I might be able to pull up some. Let me just see if I can do that.
now, in the meantime, I can read you another question to follow up. Maxine Vernez. What is the percentage of melanoma X nevi dysplastic according to your experience?
Very rare.
I have heard from David Edler. He mentioned around 30%.
Well, you see, it depends. He may see. I don't know whether that's in his routine day to day or whether that's in his, if that includes his referral practice. But I I certainly wouldn't have thought it would. Well, I don't know. I mean, maybe 10%, but not much more than that. But it certainly is not. It wasn't that common. But then, if I was to look at it from the point of view of referrals, then it would be much higher. I'm just going to see if I can. I just want to bring up, because this would be quite useful if I brought up some genital type nevi.
Now, I would like to remind people that are watching us that the new book, the WHO, the actual current book, has two tables of the differential diagnosis of dysplastic nevus with in situ melanoma, specifically pages number 84, 85, and 86. So you can go back there and you'll see that they are speaking about SAMPAS in case of a differential diagnosis between superficial spreading melanoma in situ and dysplastic nevus with severe atypia. And they introduced then other diagnosis category, lentiginous nevus with focal superficial proliferation of uncertain significance when you cannot rule out an in situ lentigo maligna. So
Can
there,
can you see this on my screen now?
no, I don't. I'm still with your PowerPoint.
Okay,
Dysplastic nevus is recognizable clinically and histologically.
okay. I was hoping that I could have put up some pictures from my file, but obviously I can't. Um, I I I uh, I tried. I'm I, I'm very pragmatic. You see, here's the thing. The patient is the start of the story. So the patient is in the bath and his or her partner's washing their back and they see this pigmented lesion and it's 6 millimeters in diameter. So the partner says, "Oh my goodness, you've got a pigmented thing on your back. It's scary. We better get you seen by the doctor." So the patient goes to the family doctor. The family doctor looks at it and says, "Oh my goodness, that could be a melanoma. Let's refer you to the dermatologist." So the dermatologist looks at it and he or she says, "Oh gosh, it might be a melanoma." And then they excise it and they send it to the pathologist. So to my mind, the pathologist's job is to tell the dermatologist, who tells the general practitioner, who tells the patient what it is. And the pathologist's job is to make up his or her mind. And if you end up with vague, it's not that I think every time you can make a definitive diagnosis. I don't think that. But I think the danger of things like SAMPAS and MELTUMP and atypical this and atypical that is that it's very easy for people to cop out of making a diagnosis. And I reckon in at least 95% of cases, if you work at it properly, you can make a diagnosis. You can say it's benign, it's dysplastic, or it's melanoma. But if you end up with 30% of your diagnosis being MELTUMP, well, you've helped nobody. I mean, there was no point in the patient's partner noticing the nevus in the first place because you, the pathologist, have not given them any answer at all. They don't know. Now, the idea of wandering around for the next 30 years, not knowing whether you had a melanoma or not, despite the pathologist looking at the biopsy, but looking at the case, is pretty bad. So I think, and particularly nowadays when we have all these ancillary tests we can do, I mean, if you've got sufficient material, you've got immunohistochemistry, you've got fish, all of the other molecular studies. Now, I know that's not available to everybody, but you can always send cases off to somebody else who has the technique and they'll do it for you with a bit of luck. So there are so many things you can do with a nevus, with a melanocytic lesion now that you couldn't do 10 years ago, that really it should be very rare that you end up with a completely equivocal diagnosis.
Now, I'm going to tie the answer to a question here from Zoom. An excellent presentation from Anuel Joshua Garcia. An excellent presentation, Dr. McKee. Greetings from the Philippines. Is there any definite role for immunohistochemistry in the diagnosis of dysplastic nevi, or can we determine them without any special immunostains? And then the second part, is there any significance regarding tumor infiltrating lymphocyte in dysplastic nevi? Is there any role for quantitation?
Well, I never used to use immunohistochemistry for dysplastic nevi. But on the other hand, I suppose SOX10 might be useful if you're not if you think there might be pagetoid spread and you're not sure, then immunohistochemistry might highlight pagetoid spread. So something like SOX10 could be quite good. I know of no, I don't know of any study that says tumor infiltrating lymphocytes in a dysplastic nevus means anything either way. I'm not aware of it, so I don't know.
Okay. I don't think I have more questions. Dr. Karina Siktom is saying excellent, amazing presentation as usual.
Well, thank you, Karima.
And Celestine Trinidad, thank you so much for a wonderful and concise talk on this controversial topic. A question is, what is your opinion on grading architectural disorders aside from cytologic atypia, as in the grading system in the Human Pathology paper by Shia in 1999?
I never saw the point of it.
Because it's either disorder or it's not.
Yes.
Yeah, I agree.
Either is or isn't.
Yeah.
I don't know why you'd want a grade disorder. It just seems a waste of time to me. I don't think it gives you, if it gave you some information that was important in terms of whether you thought it was a low grade or high grade dysplastic nevus, sure, but it doesn't. So what's the point?
Yeah. Now there is a comment here from Facebook, and there Pooja Srivastava. He's asking, can we do a lecture on spatial site neva, Dr. McKee? That's up for you.
The thing is this, you see, I'm a bit concerned about it. You see, I've done so many lectures that I post on my YouTube channel, and I've covered, you see, I was going to do a fourth lecture of benign nevi, and then I thought, but they're actually all on YouTube, so I would just be repeating myself, and so I decided I wouldn't. But if you want to look at nevus of special site, there is a lecture on them, or yes, there is a lecture on them on YouTube.
So people, you have to refer to YouTube, the YouTube channel then.
Yeah, there's recurrent nevus and all sorts of nevi there. I just felt that I would be repeating myself so much that would bore you to death. And the thing is, if I'm bored, you'll be bored.
We can also do is we can broadcast from your YouTube to the FaceTube, so to the Facebook. So we can put them live if they want to watch it at the same time, but they will be there anyway. So,
yeah,
Dr. McKee, another question: should we switch to the WHO grading soon? This is Dr. Joseph again.
Yes. I think the important thing is we've all got, you see, I think we all have to do the same thing. That, to my mind, is so important. As I mentioned, I personally am a little bit uncomfortable with getting rid of mild atypia, because I think what will happen is it'll get stuck in with low grade, so it won't, it'll be there anyway. But having said that, I think I have to do what the WHO recommend, because if we all continue doing our own thing, then we can't compare kind with kind. But if we all follow the WHO, then we're all doing the same thing, and so we can compare. For example, if we want to you see, here's a thing that I don't know the answer to. Are there significant molecular differences between low-grade atypia and high-grade atypia? I don't think I necessarily got that out of Nema's paper, although maybe it is in there and I didn't realize it. But I'm not sure necessarily whether we know that very well. So if we're all using the same grading, then people who have the ability to do molecular studies, if they do molecular studies on low-grade atypia, and somebody else does a study on low-grade atypia, then you can compare one with the other. But if people continue to use some other grading system, then it all becomes chaos, doesn't it?
Mm-hmm. I agree. So I don't see any other question that they have not been answered one way or another.
Good.
And then I think that we have to thank everybody for joining us, and particularly to you, Philip, for presenting for us for the third time.
It's been a pleasure. And next month in July, we're going to have 2 lectures on melanoma variants. I haven't quite decided what I want to talk about, but I'll sort that out, and we'll have 2 lectures in July. So thank you very much, everybody, for sharing this talk with me, and thank you for asking questions. And what will happen is Ivan has recorded this video and is going to post it on McKee Derm. And so if you have further questions, or if you have disagreements, don't forget, I'm very happy if you disagree with me. And we can always discuss things that we disagree on, which is half of the fun. So please do comment when it's posted on McKee Derm, and we'll see how we go. So thank you very much.